So I will talk about my project and our team and how we collaborate and some personal experience on this proposal. So my project really centered around breast cancer imaging and in several areas, including personalized risk assessment using digital mammography from breast cancer screening, and also in computer-aided detection to automatically detect suspicious lesions in high-resolution mammography images, and also for computer-aided diagnosis and computer-aided triage. By triage, I mean using AI to identify those most likely normal or negative cases to prioritize the rating for radiologists. There's a lot of progress in these areas, breast cancer, breast imaging, but there's also a lot of need to address some of the challenges in this area. So we know today deep learning has some challenges, and these are some of the challenges specifically for our context. Smaller data set, even you have larger data set, but sometimes you have limited annotations. And we're dealing with high spatial resolution images here. It's up to 3,000 by 4,000 size images. And also because continuous screening, many women have longitudinal examination, how to deal with and really process those longitudinal data for modeling is the challenges. And while there's a lot of progress in those AI models, but still there's a lack of trust from clinicians to use these kind of black box AI models, because physicians are barely understand how this model works, and therefore there's a process to gain their trust why this model may be meaningful with them, right? So one of our approach to address this is we want to try to leverage clinical or medical knowledges. In our view, there's a lot of established knowledge in the biomedical domains, right? So, for example, in the clinical environment, there's a lot of anatomy, biology, workflow information, auxiliary tasks in the whole clinical settings. These are actually provide a lot of information that we can leverage to augment deep learning. So the fundamental idea or the goal is to combine or using clinical knowledge to augment the data-driven deep learning. That's our fundamental technical intervention or strategy. So specifically, we have 3 tasks for this 4-year project. For task 1, we're developing a new technique to be able to formulate auxiliary tasks so that you can construct clinical meaningful multitask to do multitask machine learning. And also we have a technical pipeline to integrate radiomics pipeline, which has been shown very successful in the a lot of clinical studies. So we're trying to use that pipeline and develop a method to basically fuse the radiomics scores to a deep learning training process through the so-called curriculum learning technique. In the second task, we're dealing with, as you can see here, the multiple sequential examinations for near-term breast cancer risk prediction. So what we are trying to do here is we're leveraging a clinical concept, which is called developing asymmetry. This is actually a clinical concept radiologists use in their daily life, daily work to evaluate left-right breast, the tissue changes over time in the longitudinal data of the breast images. So we actually designed a specific model called LRP-net to reflect these clinicians' reading behaviors or philosophy or approach in their clinical practice. So we think this kind of model will be able to be more meaningful for clinicians because we're using what they're trying to use to build a customized model for risk prediction to reflect that knowledge. In the third task, what we are trying to do is to develop a image content efficient learning pipeline here. So because as you can see here, the mammography image is very large, but if you look at the lesions or the tumors are very small relative to the whole images. So you don't want the model, to just, blindly look at the whole image, right? So what we're trying to do is to develop something we call a suspicion map, so that we can actually focus the model on the model's attention on the specific region you want to look at, the region of interest, like the lesions for more efficient learning. So these are all 3 tasks, and we have a lot of real-world data to evaluate each of this methodology here. I built a multidisciplinary team. Myself have background in computational science and clinical science, and Margarita Zuli is our as a radiologist and chief of breast imaging at McGill Women Hospitals. Dr. Huang is a computer scientist, and Dr. Arfa is a rising junior faculty biomedical engineers. So actually for us, it's pretty natural to come together and with the different expertise to work on this project. Dr. Zuli is a long-term collaborator. I have several actually NCI funded grants working with her for about 10 years already. And Dr. Huang is a colleague in a AI center that I direct. So we already kind of through a lot of interactions knows fully aware what kind of expertise these people have, and then when the opportunity comes, you know where to have this be able to work. For example, Dr. Huang has experience in longitudinal data modeling for neural data, and we're thinking how we can borrow that techniques and to do the longitudinal breast imaging analysis. And Dr. Arfa is also my junior faculty, but he has a set of different skill set in the lab to collaborate. In my lab, I just wanted to say that actually the multidisciplinary research is the identity of my lab, and we do a lot of clinical translational studies working with very close, as you can see here, all these are our clinicians working together, including radiologists, pathologists, and surgeons, and oncologists. And by working with them closely, we know what kind of question that we're trying to address using our technical strengths. Even more broadly, I'm building a center at Pittsburgh for medical images. And you can see here, we actually already building a community or environment that we have a lot of members coming from up to 21 departments. Many are from clinical departments. So we already kind of have a larger pool of people working on multidisciplinary AI research, including researchers from the social science departments. So when you identify team members, it doesn't mean automatically it will work out. Sometimes it's not, right? So how do you harmonize those team members? So I think it's very important at the beginning, each of the members understand and appreciate that it's important or it's needed to work together, because for, as the program director mentioned, for SCH kind of a project, one person cannot do all the project, right? And then speak the same language. This is very, very difficult at the beginning because we're thinking very differently. If you talk to the physician or talk to our essays, they're thinking differently. So try to speak the same language. We do a lot of group meetings, even happy hours, not really talking about science, but just like hang out together. I think these are helpful actually to help understand some of the work you do, or even get to know the people better. And then, but eventually you will converge in science, because science is the number one for a proposal, right? And also, I think it's important to meet the expectation for collaborators, because when we come together, we all have some sort of expectations. It's going to be a co-PI or co-I, or it's a authorship for a potential outcome, or even for mentoring students. I think people have sort of expectation. Try to meet that expectation and balance this. I think that's important to engage people, and also respect each other's expertise. I learned this is that I think when we write a proposal, a lot of time we have a lot of ideas, and sometimes we're fairly, insisting, I think this is good, I want to do this, and this is my aim. But sometimes when you share this with your collaborator, they could have, some collaborators are very, participating there. They can give you complete different set of aims. Can we do this or do that? I think sometimes that may be not good, but you have to find out how to really addressing that and responding to that, because otherwise you will feel like, oh, I'm contributing, but then you say no to all those things, right? So I think how to balance this is also important. I still remember I have to write sometimes a very long email to explain why I think this aim is not possible, or it's not good, or it's not feasible in a 3-year, 4-year project. So I think it just have to do this. And I also remember the edits. It's not for this project, but I'm working with another social scientist in a proposal, and she actually leaves like half-page long comment to explain from the linguistic perspective how this sentence should be written in a proposal. So it's very interesting to see that. Yeah. I think it's also, in order to working with clinicians, because clinicians are just so busy. They're just too busy. So we do a lot of meeting actually in the 7 a.m. That's the best time before they do the clinical work. And it's just how we think we can make, we have to make things work this way. Finally, some personal experience. Really, it's personal experience because I don't have too much experience in this program. So I think this kind of specialization, as some of the people were discussing yesterday, I think is very helpful actually for us, for many investigators to understand this uniqueness and some of the distinct perspective of this program. And if you can ask a colleague who have experience of this, that's going to be very helpful if you have somewhere around. Inclusion of clinician physicians. In my area of research for clinical translational study, it's almost a must to have a clinician in that. But as several speakers mentioned, we already working together in those areas. It's not like just getting someone, getting a name there, right? So you're already working with someone there to build the multidisciplinary team. And also because we're talking about fundamental methodology intervention in applied applications. So I think try to tie your methodology to a single disease. I'm not sure if this is right or this is a universal, but I personally think try to single disease because you understand disease very well or a medical condition very well, and then you develop those methodology that can fit to address those nuances of these issues of a disease or medical conditions. I think that's where we needed this technical contribution to really move forward at advanced applying areas. If your proposal is too broad or too generic that it can be used for many different diseases, it's perhaps a proposal, just a classic NSF proposal. You want to try to balance the technical content in biomedical sciences. I think the reviewers or panels or the program, I think there's a balance between both of them. I think even the reviewers, I think, are looking for both. It's not just this or just that. So if a proposal that can sit between a standard NSF or a standard NIH proposal, I guess that could be a good fit, just in terms of my personal sense. And also, I think try to highlight clarify exciting overarching selling point of your proposal. You can do many different pieces of work within 4 years. You can do everything, right? But you should have tried to identify and highlight what is overarching point that it can get people or even the program director excited when they try to choose which project to fund. Evaluation plan is very important for this SCS program because I think we're talking, I think Dr. Zhang also mentioned it. You want to use real world data. That's, I think, is also a must to me. You don't want to just use some benchmark data set that's everywhere available and then say I'm doing this and that methodology innovation. I think that's not enough to tie to a real world questions. So you want to use real world data, clinical data or whatever data is real data. And also provide the exact component that the RFA is asking for. This is very important. And I know sometimes you may think, oh, these are little things. I just have 1 sentence or 2 sentences to say. But even if that's the case, I think you can still just list separately. So make sure everything is there, very clear. People can find what they are looking for. I think that's good for that. Finally, I think some high level feedback on the proposals. Writing so many proposals, including NIH or NSF or those things, I have a feeling that when we try to putting together pieces of work in a proposal, especially sometimes when you're rushing, so we're still thinking, try to tell a story or we're still thinking in a box in a way, because we're thinking, this detail, this and that. But when you have the proposal in the front of the reviewers, they're thinking different. They're thinking outside the box. They're looking, okay, this is, I know this is why and how. They're thinking in a higher level. I think if you're missing something, then you can get hurt from that, right? So that's why even you have your proposal to someone that is not expert of your proposal, it could be helpful to give you some higher level of feedback, so that help you to at least avoid some missing something or like just some little things. But you need time. You really need a lot of time ahead, so that people have time to review that. Yeah, that's all I have. Thank you very much.